From the dawn of time, cardiac arrest has been a huge problem. Firstly, when does death actually occur?
I'm not dead!
Later on, we devised methods that were appropriate for that age to try and treat the patient in cardiac arrest.
It's alive!
It wasn't until the mid-1940s that we actually were able to define and identify ventricular fibrillation and actually do something about it. And that brought us the first internal defibrillation. The 1960s brought external defibrillation out to the public. And since then, there has been a fast and ever-changing amount of treatments and modalities. But do any of these treatments work? Do they work in the way that we use them? And what does the future hold for the treatment of cardiac arrest? This will be part of our discussion when we address cardiac arrest, cracking the code. Welcome back. Just to remind you, our guests this afternoon are Dr. Bill Brady from the University of Virginia and Dr. Michael Kurz from VCU in Richmond, Virginia. So the best saved for the end, so to speak, the future of cardiac arrest. We're going to talk several things, and I think some of the things that you'll hear will be interesting and probably new to you. We'll talk obviously about ultrasound. We'll talk about the cath lab, whether we should be going directly there or not. And one of the other things we'll talk about that's not exactly new, in as much as the drugs we've been given in cardiac arrest have, to a great extent, not really changed over many, many years. But there's some evidence to wonder whether or not these drugs actually do the good we thought that they do. Or if they do good, do they do their best good or effect in the way we actually do them? So as I said, I think there's some things that you're going to hear that are going to be new to you and certainly, hopefully, interesting to you. So we'll go ahead with the discussion now. Another question that comes up, and I'd like to talk a little bit about, is the different antiarrhythmic agents. You know, we've gone through phases over the years where, you know, it was give a milligram of epi, and then it was give 1, give 3, give 5, I don't know, empty a bucket load over them is the next thing. I mean, there seemed to be no end. As much epi as you could find on a truck, you could give to a person. It was absolutely sanctioned. They thought it was great. We've since, I think, probably developed a little bit more finesse in our thought. What is your thought to the benefit, and I ask both of you this, to the benefit of the antiarrhythmics we use in a two-pronged question here? First of all, do you think they really do any good as regards the patient being discharged from the hospital? And if they do good, is there a time frame where they're at their most effective? So, you know, you give them in 5, 6, 7 minutes, and we know they really probably have a positive effect. But after that, maybe not so much. Or can you give them at any time?
You know, how many hundreds of thousands of milligrams of lidocaine have we all pushed into patients? You know, it's interesting, with the amount of lidocaine used, the robustness of the research supporting it is not there. Okay? There's very little to no research that shows that lidocaine does a whole lot other than perhaps anesthetizing the veins, so you can give drugs that hurt and not hurt the patient ultimately. Antiarrhythmic agents in most people with out-of-hospital cardiac arrest don't ultimately alter the outcome. There's more of a track record with amiodarone in terms of research. It certainly does show that patients are resuscitated more frequently with amiodarone compared to other agents or placebo, but it does not show a survival benefit. And there may be a subset of people in which they do work, but right now, our understanding of the science doesn't allow us to identify. So it's not wrong to give these agents in the appropriate patient based on the guidelines and based on your local protocols, et cetera. But it would be wrong to put undue focus and attention on giving meds, antiarrhythmic agents, or anything else, and again, not doing the basics we've already mentioned, chest compressions and appropriate defibrillation of shockable rhythms.
Is there a time frame that these medicines work best in?
Any therapy in cardiac arrest works better early on, okay?
And apart from that answer, is there another time frame that these...
there is literature that suggests that antiarrhythmic agents may work more appropriately early in arrest, but again, even those studies have attempted to separate out pure drug effect versus early use. It's very hard to do that. So you know, my thought is anything precordial thump used early in arrest has a better chance of precordial thump used later in arrest. So I don't know, Mike. What do you?
I absolutely agree with you. So the only caveat I would make to that antiarrhythmic literature is, and Bill quotes it exactly the way it appears, which is it shows clearly an improvement in ROSC and no out-of-hospital benefit, no survival from hospital benefit. Absolutely. I think the one caveat I would address to that literature is that all of that literature was done in the pre-hypothermia era. Okay, when you made it to the hospital, your survival rate out of the hospital was less than 5% probably to begin with. And now we're seeing comprehensive resuscitation centers where the resuscitation rate, the discharge from the hospital rate is closer to 40 or 50 or even 60%. Somewhere between 55 and 60% seems to be the new ceiling. If that's the case, these antiarrhythmic drugs provide the necessary predicated step to survival out of the hospital, which is you have to have a pulse to survive to get out the door. So in that, to that extent, I would argue that they're beneficial because you have to have that step in order to survive. But I absolutely agree with you. When you look at the literature, when no one comes out of the hospital, whether you get the antiarrhythmics or you don't.
You know, you bring up a good point, if I may interrupt.
Please, go ahead.
You know, with therapeutic hypothermia, do we have to redo all of our research? You know, people would come into the hospital, they've been resuscitated, they're not showing appropriate, you know, higher response.
Right.
You know, the appropriate tests are done, EEGs are performed, and the patient's declared, you know, brain dead,
Right.
and support is withdrawn. But now with hypothermia, and the interruption and the evil internal cascade of injury that hypothermia can provide, do we have to relook at all these different interventions?
I think we need. I think what we need to do is look at the way we have practiced for, I would argue, since the advent of resuscitation, cautiously. The example you provide about neurologic outcome is perfect, right? So there is, for the better part of 3 decades, we have defined brain death and prognostication post-cardiac arrest. You can do it in the first 12 hours. It is clearly laid out. You know, do they have corneal reflexes? Do they follow commands? What's their GCS score? And then you could tell in the pre-hypothermia era, are they going to make it 3 days? Are they going to make it 5 days? Will they ever survive? In which case, you're right. You could just stop early on when it's futile. What we know from neurologic prognostication, in the presence of therapeutic hypothermia, you have to throw all of that out the window, right? And their neurologic presentation on arrival has absolutely no correlation with their neurologic function on the other side of cooling them, assuming they get post-arrest resuscitation care. Now, if that, the fundamental prognostic measure that we have used for decades, we have to rethink, then your point's well taken. Do we have to rethink everything? Do we need to look at the way we resuscitate people, how we manage their airway, how we cool them, et cetera? What drugs do we use? I think it's an important thing to consider.
And in keeping with the order that we've gone in so far with the new AHA guidelines, we've done the CAB, and of course an important part of this, the AHA guidelines, is where they address, once you've got ROSC, now of course we address more than we used to in the past, what do we do with the patient now that we've got them? And to some extent, we were getting ready there to do hypothermia, and you've started that for me. A question to maybe Dr. Kurz, and a lot of people I don't think understand. You, Dr. Brady, refer to the evil cascade of damage. Dr. Kurz, can you probably, why does hypothermia work? Why are they better off cold than warm?
We wish we knew.
It interrupts the evil cascade of
That's
damage.
exactly the good answer, and that's probably
Next
the most
question,
precise.
please,
That's probably the most
Don't have a
precise answer
question
that
to
we
follow
can
up on
give. The reality is that in coming to the new era of post-resuscitation care, we've done bad science. Okay, since
That's the evil part.
Since 2002, when the original Haka and Bernard trials proved that therapeutic hypothermia worked post-cardiac arrest, our new stance has essentially been throw everything in the kitchen sink at these folks. And so whether it's the hypothermia, it's the oxygen limiting ventilation, it's the volume limiting ventilation, it's the glucose control, it's the continuous EEG, whatever it is in the comprehensive post-resuscitation, recipe, we've thrown all of it at the patients, and we do better. Clearly there's an improvement in mortality. Clearly there's an improvement in neurological outcome. Clearly there's an improvement in survival to discharge. The problem is I can't really tell you what does it. And if I can't tell you what does it, and then I can't really identify what the mechanism is. So
there's an old expression that covers that about throwing stuff and seeing what sticks.
Well,
I mean, Mom's chicken soup was great and it was good for you, and we all knew that. But was it the peas that were good for you, the carrots? If you put so much stuff in there, how do you isolate what's the actual defining thing that's making it?
In the literature, we have proven that therapeutic hypothermia works, and we have proven that this care bundle, post-resuscitation, works. And I think you can make a reasonable argument that in many places it has become the standard of care. Well, if it has become the standard of care, it becomes very difficult to convince an ethics board to then start to peel away some pieces of that care to figure out which part of the chicken soup is really the part that makes you feel better. If it all works and everyone adopts it, then it becomes very difficult to justify peeling the parts away. Everyone is afraid you're going to peel away the part that works.
So if we're talking about the care and multiple things in it, and earlier on we talked about antiarrhythmics, it's probably worth remembering that we also have the vasopressors. And maybe ask Dr. Kurz, what's the present state of the knowledge and research on vasopressors in cardiac arrest?
Well, much like Bill referred to, it seems that if you use them early, they're probably beneficial. Certainly in preclinical studies, pressors look beneficial. There's some recent literature out of Michigan that suggests that vasopressors given in the first bit of the resuscitation, I think it is within 4 minutes of a loss of pulse, and that in fact they're beneficial. But the reality is that most resuscitations don't start within 4 minutes of losing pulses. That almost assumes that you're in a witnessed environment where there are providers with all of the equipment ready to go.
Nearly an in-house type of scenario,
right?
As opposed to a pre-hospital scenario.
Right, or in a pre-hospital scenario, about the only way you get there is you got picked up for something else.
The patient arrested in front of you.
Exactly. And so short of that scenario, there's plenty of literature. There's lots of preclinical animal literature that suggests that these drugs are beneficial. And in fact, that perhaps even a combination of epinephrine and vasopressin is superior. When you get to actual human trials, where these drugs have been put in practice and put against either placebo or, quite frankly, none at all, the literature is less clear, to the point where, in fact, there seems to be a loose association between receiving those drugs and a worse outcome. I think for all of the reasons why research in the uncontrolled environment in pre-hospital medicine is so difficult, make those study findings difficult to interpret in light of the preclinical data that we have. But all things being equal, that's what the literature shows, and I think that we need to perhaps evaluate when and how we give those drugs on a more individualized basis.
And Dr. Brady, I'd ask you maybe, I mean, obviously we've discussed the antiarrhythmics and the vasopressors. There are a lot more drugs in the box, so to speak, that we tend to see more as, for whatever reason, we have a more prolonged arrest. Are there any drugs that you think in that group that are not in that first two categories that we spoke of that are particularly good, and maybe any that you think, we'd just be as well off without them?
Well, there's still a lot of drugs in the box, but if you think about calcium, magnesium, and sodium bicarbonate, those are drugs that, again, have been around as long as lidocaine, if you look at the 1970s TV shows where resuscitation is occurring and the physician over the radio is saying, give a amp of sodium bicarb and, blah, 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 blah. The literature, I think, has demonstrated that in all comers cardiac arrest patients, none of the three of those make a significant difference. Calcium, for example, in out-of-hospital or even hospital-based cardiac arrest, all comers, no value. Same sort of thing with magnesium, whether you're using it as an antiarrhythmic agent or elsewhere. There's a number of trials that show no benefit, some of which actually show a detriment relative to magnesium, and I think sodium bicarb as well. But that doesn't mean that there aren't niche applications of these three drugs. Calcium, for example, in an early hyperkalemic arrest may be of benefit. Magnesium, the same thing. Sodium bicarb, the same thing for hyperkalemia. So there's niche applications of these drugs, and you have to think and also have the luxury of knowing a little bit about your patient to identify which drugs may help you. Of course, atropine has been removed, not because it did harm, but because it didn't do any good. It's not wrong to give atropine in a Brady arrhythmic arrest or asystolic arrest, but the benefit is negligible, if any. But that doesn't mean that atropine shouldn't be used in pre or post arrest when patients have compromising bradycardia. It's a good drug and should be used there, so don't confuse it. And I think the last medication to mention, not necessarily in the EMS drug box though, is a fibrinolytic agent in cardiac arrest. A number of trials have demonstrated, in essence, futility in the use of fibrinolytic agents in all comers with out-of-hospital cardiac arrest. But again, in niche applications, particularly in the hospital environment, of someone with a known or suspected pulmonary embolus that arrests before your eyes, there may be some benefit to very early use. But in general, the medications don't resurrect the dead.
So I was sitting around the other night and thinking that we were going to do this video and trying to do some research on it. And I happened to run across some statistics from the London Fire Brigade or London Ambulance Service. And they do about 10,000 cardiac arrests a year. And there were some statistics that I thought, wow, maybe there are things we should talk about today. One of the obvious things is out of the 10,000 cardiac arrests they were quoting, they only attempt resuscitation in somewhere between 4,500 and 5,000. So they seem to have a different benchmark for or willingness to accept death. I think it's not unreasonable to say that a lot more of them in America are subject to some form of probably futile resuscitation. But the thing that they did say that struck me the most was, and several years ago, and it sort of ties into this, the AHA, definitive care as soon as possible, time is muscle, with a diagnostic 12 lead and a good clinical history behind it, and that 12 lead is transmitted, and somewhere or other, I suppose what we would call here an attending of record, receives and interprets that 12 lead. Those patients don't go to the ER. They go straight to the cath lab. And I suppose to both of you, my question would be, if time is muscle, and these patients now are not the patients who need resuscitative efforts, these are patients who are headed towards angioplasty and or stenting. Why are we bringing these people to the ER? Are we not being somewhat disingenuous? On one side, we're preaching definitive care as quick as we can, yet we're stopping them off for 25, 28, 30, 40 an hour in the ER. So how do you equate this? How does this make good sense?
I don't think you should stop in the emergency department. And as an emergency physician, I can tell you that in the emergency department, we offer nothing that the cath lab doesn't already offer. That being said, there's a small subset of folks for whom you described who need ongoing resuscitative efforts because they've lost a pulse, they're in cardiogenic shock, and you don't think that they physically will have a pulse between the trip, the ER to the cath lab. Or maybe they need an invasive airway because with their MI has come pulmonary edema, and so they're satting poorly, and that person needs an invasive airway. Those very specific measures aside, I don't think there's any reason to stop in the emergency department. And because in the emergency department, I do not offer the one thing that these folks need, and what they need is rapid access to angioplasty and stenting. So we in Richmond, we have started doing that where we'll just, if the patient is stable, we'll completely bypass the ED. Why do we wait 20, 30, 40 minutes? A lot of times it's because the cath team is not ready. If it's the middle, the reality is with the proliferation of cath hospitals, for example, in Richmond, I have 7 for a population that probably needs 3. There's not enough volume at any one hospital to justify putting a cath team in-house 24/7. That means they have to respond from home. That means you have to give them 30 minutes. That means at 2 a.m., when the patient arrives and arguably could go directly to the cath lab, even if I get pre-hospital transmission and I gain 10 minutes, 15 minutes, I still have to have somewhere to put the patient until the cath team is ready to go. And that place is not in the cath lab where there is no personnel.
Absolutely, and I don't think anybody's arguing that. And I had this discussion before I came in here today with another physician, and practically mimics exactly what you're saying to me. And my answer to him was, if all things are equal, and the cath lab is available, and this patient does not clinically meet the criteria where it's safe to them for them to go to the cath lab, what I'm hearing is a bunch of processes, a bunch of people problems that may possibly be delaying the patient getting the definitive treatment they need. And I think he agreed with me, you know, and he said, well, you can't, told me, he said, you really can't be that naive to think that we can flick the fingers and the cath lab will be open any second. But the question that I was asking was, as I said, all things being equal, should we not just be bringing those patients to the cath lab and bypassing any other stop on the way? I'd ask Dr. Brady, maybe your feeling on that.
No, I agree. I think, and I think many hospitals are doing that. If the patient presents at the appropriate time, the cath lab is open, they can just wheel right on through. But at the same time, it doesn't do any harm for a quick 30 seconds still on the EMS stretcher to make sure the airway's okay, to make sure perfusion is appropriate to sustain life for the next 10, 15 minutes. Because once someone's on a cath table, they still have to prep the patient, they still have to gain access, they still have to get up into the artery, identify the culprit artery, and get in and open it. So it's not, again, an immediate process.
Absolutely.
So I think eyeballing the patient, making sure that they're safe and appropriate, because like it or not, I mean, I agree with you that the cath lab provides a lot that the emergency department can't do, but at the same time, the emergency department can resuscitate better than any other place in the hospital.
Absolutely.
In terms of stabilizing a blood pressure, providing an airway. So I think, again, as Mike said, moving them aside, and if the system is working appropriately in your facility and the lab is clear, they can go straight up. No reason to stop. But the reality of the situation is it does take time to activate a system, even during the daytime.
Certainly, absolutely, and I'm accepting of that, absolutely, but this is why I'm sort of asking that. The question maybe can't easily be answered, but all things in place, why are we stopping in the ER, was my question.
But in a perfect world, every hospital would have a cath lab with an open bed and a team that's sitting there waiting for the patient to arrive. But then let's take that into the pre-hospital setting. Every community is going to have an EMS unit with advanced critical care capability every 8
Available
blocks.
for every single
every 8
call.
blocks
Yeah.
with a response time of 32 seconds. So, it's resource allocation. And, as Mike says, certain places, certain cities have many, many cath labs so that the volume is distributed so that it really isn't, frankly, cost effective, or a hospital isn't able to have a cath lab open 24/7.
And I think we have to, we can live in these ifs and ands worlds. I mean, if all things were equal, I'd be tall and I'd play in the NBA. The world, it's just not, the world isn't fair and it isn't equal, and you got to accept what you got. What worries me, and this question was asked to this particular angio doc in this interview that I watched, All the same things that we've spoken of came up, and everybody is identifying, the patient who is not stable enough to be in the cath lab. The cath staff are there. They can come and take care of him. There's no problem. The table is available for him, but he's not well enough. And then there were questions, well, he needs a definitive this, he needs labs drawn here. And the doc's answer was, I have doctors and nurses in the cath lab too, We can do this ourselves. So it's just a thought, if we could, would it not be an advance in care? For I agree, it's only a certain set of people that we would bypass them. And that was the purpose to my question. I just thought that there maybe was a gap there that we could fill.
And we've been talking about the diagnostic ECG, and here, I assume we're talking about pathologic ST elevation in the appropriate number of leads, or a new left bundle branch block in the appropriate setting. But there's other scenarios.
His answer, when the other scenarios came up to him, because unquestionably they bring people, they bypass the ER, they end up in the cath lab, vessels get squirted, and there's no occlusion anyway. And he was asked, well, how do you justify using the time? And he said about 10% of the people who come up there turn out not to need ballooning or stenting, and it's basically a false positive. And he said that 10%, he was fairly comfortable with that, so as he wouldn't have the converse, that there wouldn't be somebody missed.
Of people with STEMI, documented STEMI, abnormal electrocardiogram, positive markers, appropriate signs and symptoms that go along with the presentation, somewhere between 10 to 20% don't have demonstrable coronary lesions.
On cardiac angiography, yes.
Exactly. So vasospasm or clot formation, they lysed it, and it's gone. But let's take another step back. I mean, can we talk about people that don't have ST elevation, or people that don't have a left bundle branch block? I mean, what do you think of them?
Did they go directly to the lab?
Or should they go to the cath lab, whether it be directly or rapidly within 15, 20, 30 minutes?
For those folks, I think you need some form of evaluation in the emergency department. And I think some combination of whichever biomarker you would like to use, whether that be point of care or rapidly turned around. In addition, the appropriate, an evaluation for the appropriate clinical scenario, and then a pretty good clinical story for ongoing ischemia. Yeah, I don't think that we should be holding up folks who clearly are having some supply-demand mismatch and not open that up. I mean, if what we're looking for is occluded vessels, then we ought to open them. I don't know that handoff necessarily, in the absence of the diagnostic 12 lead, should be medic cath attending.
Right.
In that instance, I think there is a huge opportunity for the emergency physician and the expertise that the emergency physician brings to bear.
Absolutely.
And
I think in this scenario that I was proposing, want of a better way of saying it, the no-brainers, and not the outliers, and not the ones who have a non-ST elevation MI. Those are ones clearly where somebody with particular expertise has to come in there, consider the differential, all the possibilities, and then make a decision where the eventual destination of that patient should go. Absolutely.
Yes.
I'm not suggesting we send people up to the cath lab and the cath lab be the people effectively who say whether or not they're having some form of an acute coronary syndrome. That's not what I'm suggesting. Okay. Just off the top of my head here, I have one last question before this for you. Lactate testing in the acute coronary syndromes and MIs. Okay. Any place for it? Any value to it? Or no, you wouldn't. Well, when we're looking at the sick versus not sick, acute coronary syndrome patient or MI.
I think lactate is probably best used for the pre-hospital and emergency department patient focusing on sepsis. I think it helps you pick up the patient that is less perfused than you think, just based on your traditional, history, physical exam, vital sign look. Picking the patient up from a nursing home, the older patient from home, the younger patient from somewhere who is a little tachycardic, you know, vomiting, a little weak, a little altered, and they've got a lactate of 0.5 versus a lactate of 5. Very clear, very different approach, pre-hospital and hospital-based. You know, extrapolating that to the cardiac patient, I personally don't think, with our current level of understanding and application, that a lactate really helps you diagnose an ACS event. I think that if you're looking at hypoperfusion in that setting, then certainly you could consider doing it.
But hopefully you would have noticed the sick versus not sick.
Yeah, again, but,
You know.
but again, particularly in younger people, they can compensate physiologically much more so than, say, older people. And you may be surprised by the degree of hypoperfusion that a lactate suggests when you compare it just to the eyeball,
So
you know,
some
history,
form of
physical,
a cryptic state that they're physiologically well able.
occult shock.
Occult shock.
Yeah.
The young guy has this but doesn't look ill yet because he's young and physiologically pretty decent.
Compensates well.
Yeah.
So the lactate, the measure that lactate gives you is essentially tissue perfusion. And what it really is a surrogate for on a cellular level is oxygen debt. That's what it's all about, oxygen debt. Now, if it were a great marker for acute coronary syndrome, we would use it in place of troponin. And you wouldn't draw troponins, you draw lactates, and you'd move on where the lactate moves. I just don't think that, except in the enormous acute coronary syndrome where a large part of your LV is at risk, when we talk about that, you know, there's cardiogenic, shock that follows, et cetera, and you have a huge mass of underperfused tissue that then lactate shows up, let alone does anything for you. And I think those scenarios are probably pretty apparent, except as Bill points out, in the young, well-compensated adult. Where I think lactate helps you is exactly where Bill suggested. It's in the person with occult lack of perfusion somewhere. Sepsis, I like it for sepsis. Other shock states, we use it a lot in the trauma bay. It's wonderful for kind of ischemic gut, dying gut that you can't otherwise kind of get at without very, very invasive testing. That's where I see really a utility for lactate.
And that's what we've done a whole series on lactate testing. So really, in summary to that, all the things we've talked of before, but you don't see a particular specific application in acute cardiac syndromes for lactate testing. No. Okay. A last question, and this is something that's addressed to some degree in the new AHA guidelines and is becoming spoken of more and more, is the use of pre-hospital ultrasound in the cardiac arrest scenario. Dr. Kurz, anything that you could say on this? Do you think it's a good idea? Do you think it's just crazy and ultrasound testing has no place in an ambulance?
I think what we're finding is that ultrasound is portable. It is incredibly useful, and it provides imaging, limited imaging in niches or environments where you can't otherwise get it, right? And so, obviously, in the pre-hospital environment where you have no imaging at all, there's some utility there. I think in a well-trained set of hands, an experienced operator, there are some views that may be of some utility in the pre-hospital setting. Specifically in cardiac arrest, I like it for the idea of correctable causes, right? So a tamponade that you might be able to intervene upon, for example. The other reason I like it is a reason to stop resuscitative efforts. There is, I think, very little utility, or in fact futility, to continue to resuscitate someone who has clear cardiac standstill as demonstrated on ultrasound.
I wouldn't argue that it would be a valuable tool. It would be an objective tool. It would be something that, if you're just asking the question, is there mechanical activity or not, then it's very simple and easy to do. It would be something that would be easily obtained and would be very objective, black and white, yes, no, is there motion or not, we need to stop. Yeah, you can do that, but that's going to cost you, you know, $6,000 or $7,000 per truck, not to mention the training, the competency, etc. So,
training, competency. Dr. Kurz, how hard is it to train a competent EMS provider to do this particular, and we'll go for one particular window, one particular exam in this particular case, of the many views that you can take of a heart. How difficult is it to train somebody and have them reasonably reliable that you would, based on what they've told you, be willing to make a decision?
This is an area of literature that I'm not as familiar with. However, I have a colleague who, this is all they do, is director of ultrasound, and he runs these classes all the time, and he is pretty comfortable with being able to train a EMS provider to do limited cardiac ultrasound. So exactly what you described.
Limited.
Windows and exam solely for the purpose of determining tamponade, yes, no, and determining cardiac motion, yes, no, right? To teach them everything they need to know and be trained to be able to do it reasonably, it takes about 8 hours.
So that brings me to the final question, and it's pretty much an open-ended question for either of you. If you had your wish, what is the one single thing that you would like to see brought into the resuscitation field, and one single thing that you think we as EMS providers can do better and therefore give better outcomes to the patients? So you get your gadget or gizmo, and the one thing you think we need to improve on the most to improve morbidity and mortality.
yeah, you know, so you're probably not going to like this. Probably not going to like this, so I'm preparing you for it, Tom.
Okay, thank you.
But what I would like is EMS agencies, fire rescue services, fire departments, hospitals, emergency departments, to get out and train the lay provider.
Absolutely.
With chest compression, hands-only CPR, and using an AED.
Absolutely.
I had the interesting opportunity to encounter a person in cardiac arrest in a large city that begins with W and ends in Washington, and had an awesome response from fire, police, rescue, excellent response. But of the 100 people that were sitting there watching me do chest compressions, no one did a thing.
Mm-hmm.
And I think we all know that out-of-hospital cardiac arrest is going to do best with early intervention. And who's going to provide that early intervention? It's the guy that steps right
Absolutely.
over the person. That guy needs to stop,
Absolutely.
say, call 911, get me an AED, and start doing chest compressions. So if I had the one gadget, the one whatever, it would be for energizing the lay public to intervene in cardiac arrest in a meaningful sense, long before 911 is called, long before EMS is on scene, long before the patient is transported to the hospital. Yes.
Dr. Kurz, your turn.
That's what I was. Bill's taking my thunder, because
He
what I
does.
was going to say is
Sorry
I don't.
about
Well, no, I don't really need a gadget, right?
No.
Because all you need is
He gets the
all you need is 2
gadgets.
arms.
What would you
Fair
like
enough.
to do?
So
to do better?
so I think we can agree that what you need is AEDs, right, everywhere, like public access defibrillation. There's plenty of literature on this point, and clearly it makes a difference. All you have to do is look at the experience at O'Hare Airport, right, where 1 million people pass through a day. They have a cardiac arrest at the airport, I think every 3rd day or something, and there's a AED within every 90 feet. And or a 90-second sprint or something. They're they're everywhere, right? They're ubiquitous,
Mm-hmm.
and they have a survivor a week or something there, right? While we all can acknowledge and appreciate why that works in that setting, right? There's AEDs, there's people trained to use them. The one thing I think gets lost there is that part of the issue is that it's ubiquitous. We seem to have a fundamental disconnect in municipalities. They all want to spend money on AEDs, and they want to put them places. It doesn't help if the person you're trying to save arrests across the street from an AED, and you don't know it's there.
Nobody knows. It's
Okay,
absolutely.
and so while municipalities put in place laws that allow public access to fibrillation. They should also put in place some way to register and track those AEDs so that dispatch has that information, so that at a resuscitation you can be directed across the street to an AED.
911 person can tell you you're no different than the fire department. Your closest hydrant is
right, exactly.
Your closest AED.
You should call 911. They start you with CPR instructions in 15 seconds, and they say, "Is anyone else there?" They hand the phone across, and they say, "I need you to go get the AED. It is across the street in the whatever building. Go through the glass doors, down the hallway on the right. It's 90 feet. Grab it and bring it back, and I will instruct you how to use it."
Yep.
Until municipalities understand that we need laws in place that facilitate that with dispatch, and then remove the liability for the individual business that decides to put one in, and reimburse that business if, in fact, the AED is not used on their property, right? Until we put laws in place that do those things, we will not have the ubiquity that those things, I think, are the outcome change, the ubiquity that those things are predicated on.
So, what would you see, one thing very briefly, please, what can you see EMS providers, pick the one thing that we need to work on to do better to improve outcomes in patients in cardiac arrest, out of hospital cardiac arrest?
I think, so we've come full circle. Bill started with this. The emphasis, the paradigm shift that needs to occur is that CPR is what we should be doing.
Better CPR.
Better CPR, and nothing should come at the expense of providing that CPR.
I think you get his answer.
Short of shocking the rhythm that's shockable. Everything else, the airway, the drugs, you want to put an easy IO in them, whatever it is, should not come at the expense of the quality, the continuous quality CPR that you do.
Dr. Brady, your suggestion?
Impression.
So I think agreeing number one with Mike. Number two, I think I'm gonna pick the next valuable intervention is early shocking of shockable rhythms. And again, I'm gonna take that even before EMS arrives and have the AED used, so that when EMS arrives, they got a patient with a pulse. They don't have to do anything. They put them on the stretcher and drive them to the hospital.
Well, that's all we do as ambulance drivers, isn't it?
You do a little bit more than that.
So good to us.
It's just a taxi with lights, right?
So there we go. That's a, I would like to say, brief overview of out-of-hospital cardiac arrest treatment, but it wasn't really that brief. But I think we covered a whole lot of stuff. I hope you enjoyed it. If you have any questions about this video or any of the other videos, please feel free to email me at video@orangecountyva.gov. And I'd also encourage you to visit our partner site, clinicalbraintraining.com and fire-ems braintraining.com. Thank you indeed. Goodbye.